Welcome to today's webinar, Oral Health of Children and Youth with Special Health Care Needs in Primary Care, provided through a collaboration between the Pennsylvania Medical Home Initiative, a program of the Pennsylvania chapter of the American Academy of Pediatrics, and funded by the Pennsylvania Department of Health. This webinar, led by Dr. Alicia Risner-Bauman, aims to specify the challenges preventing effective oral care for children and youth with special health care needs, to identify interventions that can be used for medically compromised children and youth, and to describe interprofessional communication and referral systems needed to treat children and youth with special health care needs. I am Eileen Thompson, the Program Director of the Pennsylvania Medical Home Initiative at the Pennsylvania chapter of the American Academy of Pediatrics. This webinar is being recorded. The recording will be available on both the Pennsylvania Medical Home Initiative website and will be posted on the University of Pittsburgh Internet-based Studies in Education and Research website. For CME purposes, please be advised that none of the speakers today have any disclosures. Please note that the information presented in this webinar is educational in nature and does not necessarily represent the views or policies of the Pennsylvania chapter of the American Academy of Pediatrics or the funders. Now allow me to introduce our presenter for today's webinar, Dr. Alicia Risner-Bauman. Dr. Alicia earned her doctorate in dentistry at the University of Iowa and has a diploma from the American Board Special Care Dentistry and has a fellow from the Academy of Dentistry for Persons with Disabilities. She served as chair of the Pennsylvania Dental Association Access to Oral Health Advisory Group, serves on the board of directors for the Pennsylvania Coalition for Oral Health, and is the special needs dentistry consultant for the PA Head Start Association. She is also a member of the Health Advisory Group for the Governor of PA. She has been an active policymaker with the New York State Dental Association and the NYS Special Care Dentistry Task Force. She worked as an assistant professor at LECOM School of Dental Medicine. She's currently practicing at a developmental center for the New York State Office for People with Developmental Disabilities. She has several publications and a history of presentations relating to advocacy and treatment for complex patients and access to care. She continues to work as a dental consultant, educator, and special needs advocate. We are so delighted to have Dr. Alicia Risner-Bauman present on this timely and very important topic for primary care clinicians. At this time, we will begin our presentation. Dr. Alicia?
Thank you so much. So as we dive into this topic, I'm going to, well, it looks like I'm missing a slide. That's kind of a bummer. Hold on. There it is, out of order. See, I caused all kinds of trouble already. As we dive into this topic, I'm going to be utilizing the Special Care Dentistry Association definition for special needs, person with special needs. Essentially, anyone who cannot receive care easily, such as go to the dentist, accomplish a task, and leave, is classified as special needs. Some of the techniques and things that we'll be talking about will be applicable to all age groups and to all ability levels. Oral health care involves not just caring for teeth and gums, but for all the factors that make a person healthy. So an interdisciplinary approach to care is needed to assure overall health. Individuals with special needs are at high risk, and you need to avoid being accusatory or judgmental when you're evaluating a patient and the caregivers that bring the patient to you. You can see in the picture on the left, this mouth, this is a terrible case of bottle rot, as it used to be called, or early childhood caries. You can see the pulps are exposed, there's draining fistulas, and there's drainage coming right through the pulp channels. The individual who took over care for this person was a grandparent who got into the game quite late in the story. So we need to remember that when we are evaluating the patient, we need to also evaluate the caregivers and understand that there may be a lack of understanding about what the oral care needs are or how to provide care. We often have caregivers who are just taking over care for someone, and we're also all too familiar with the number of grandparents caring for very young children. So transitions can be very difficult for everybody involved, and we need to know the whole story in order to truly understand the needs of the patient and how to address those needs in the care plan. The challenges faced with oral care are not new to this population. With the deinstitutionalization of individuals into group homes, more people staying at home, and because of the Americans with Disability Act, providers in general practice are finding more and more often that individuals with special needs are seeking care in the general care setting. Currently, the only dental that Medicare covers is for TMJ therapy, but work is being done to develop a dental benefit for Medicare. Some of what we will discuss today may be covered, so it doesn't hurt to check each person's plan or to submit to medical insurance when billing for services. How the individual is designated for services can influence their coverage. If they are not designated as having a special need or living in a group home, they may not have certain coverages. Some have supplemental plans, and the plans are constantly changing. And in Pennsylvania, there were some new rules just implemented for individuals who are dual eligible for both Medicare and Medicaid. So if we think negotiating insurance is difficult as providers, imagine the families and the individuals trying to negotiate what's going on. It's often very useful to get a caseworker involved and to have them help not only the family negotiate the insurance, but also to have the caseworker help with pre-authorizations and who needs to talk to who. So when it comes to taking care of the individuals and some of their limitations, saying that something needs to improve without offering a way to improve it is not really good enough. A plan has to be developed and revised with each visit in order to determine where there is success and what more needs to be revised. Everyone has to be on board with the plan and maintain the momentum from the first visit. Unless you have a child or someone else with special needs that you take care of, it's hard to imagine the daily challenges that some people face. It is exhausting to deal with a challenging individual. Now add caring for yourself and other family members. In professional settings, many caregivers are stressed out that the patient will act up and they will not be able to come back, or they're afraid of wasting the doctor's time. There's often a fear of the child being hurt or the provider being hurt. Something that can be helpful is to bring the caregiver and the patient to the office for a meet and greet or a visit that no care is provided, but simply seeing the office, meeting the people involved, possibly taking photographs of the place and the people to create a storyboard. That's something that's been very helpful and is very useful when you have individuals on the autism spectrum. So let's get into the oral part. I'm sorry, but for some reason these slides aren't matching up with my slides, and I'm going to skip a little bit because I want to keep them in the right order. And I do apologize. I probably sent something that was the wrong. Okay. I apologize. I'll get you back here. Patients, behavioral, and okay. Very often caregivers do think that they are doing a good job with oral care. If you take a look at this picture here, you can see that on the top we have heavy plaque and we have a lot of redness of the gingiva, yet if you look at the lower teeth, they look pretty good. This person's a lip squeezer and pushes the lip against the teeth on the top. So encouraging the person providing care to get that lip out of the way is imperative. The goals of the home plan are to get the plaque off the teeth and to remove the bacteria that are causing the problems. So each goal has to be broken down into pieces and addressed individually. Some of the techniques will need to apply to the primary goals, and each plan will take each of the goals and adapt it to the individual. So in this case, again, looks like they did a good job brushing when they came in, but if you look at the pink, which shows where the plaque is located, you end up seeing that actually they left a lot behind, and that needs to be removed with further brushing. So as we develop a plan, we need to remember that it has to be patient-centered. As soon as the plan or the execution of the plan becomes too difficult or too complicated, most people will give up. So the plan has to build on itself by looking at what's been successful, what's been a failure. And in any time that you're trying to add something, each time you want to make sure that the part that was done initially has been mastered before moving on to something else. Factors that are going to be involved in an oral health plan are going to involve evaluating the patient and the caregiver, as well as evaluating what are the disease problems that we're trying to control, what is the education level that we're dealing with, and what kind of education might we need to provide before they will understand the plan or the need to have a plan in the first place. We want to make sure that as we're teaching how to care for somebody else, we talk a little bit about infection control. Family members very often don't think about the fact that as you're brushing someone else's teeth, there's a lot of splatter, and those are germs that are being splattered, and sometimes taking some measures to wear a mouth mask or gloves while providing care is important. We're going to also want to take a look at what preventive modalities are we suggesting? Are we recommending a rinse when the person really isn't able to swish and spit? And do we need to prescribe that rinse to be applied and then removed rather than swish and spit? As I said before, we want to make sure that in the development of the plan, we have the very first step being the evaluation. We need to be evaluating the person responsible for care, because that's just as important as evaluating the individual receiving care. For example, if mom's teeth are all missing at 30 years old, oral health may not have been a priority in her household and may still not be. However, loss of their teeth may be motivational to try to do better for their children. As we develop an oral care plan, we also need to keep in mind factors that affect the plan. Are there transportation issues? And this has been one of the major issues throughout the state of Pennsylvania, looking at the distribution of dentists and dental homes, medical homes, and what is the distance between them and how easily can we access them and what sort of transportation is available. Are there bus schedules we need to keep in mind when we're making the appointments? Will a ride share be necessary? Can the family afford the items that you are suggesting? As we talk about care and we say, oh, well, you should get an electric toothbrush, can they afford an electric toothbrush, or do they need to be shown how to use a manual toothbrush properly, or do we need to see whether or not we can get some electric toothbrushes donated to help the people that truly need those, because they're not cheap. We need to keep that in mind. Can the family, do they live in a group setting where keeping track of one's supplies can become difficult? And it may seem sensible that, well, they're going to label it. Not always. Sometimes we want to think about labeling items in our own office using a Sharpie that we know is going to be permanent to make sure that nobody's going to be sharing toothbrushes and that they have a kit that keeps all of their hygiene items together and separate from everyone else's. Do we need to work around a school or a work schedule? If the person responsible for getting the individual to appointments can't make the appointments at the times that we have available, they're not going to keep those appointments, and they may not tell you that that's what the problem is. We may need to coordinate visits with another provider in the same building in order to best utilize the patient's time and the agency's resources. In some situations, you have 2 or 3 staff people accompanying an individual to an appointment. So if you have an FQHC that has a medical side and a dental side, perhaps both of the receptionists need to be communicating with one another to try to coordinate the visits and make it easier for everybody all the way around. So all these factors can influence your plan and the development of the plan and the execution of the plan. Most caregivers receive very limited training and are very cautious when it comes to providing oral care. So remember to design the plan to a level that everyone involved can understand and appreciate. The plan will be changing, so be sure not to overload during the initial discussion. Don't be afraid to ask if the information needs to be divided up for better understanding, and information overload can torpedo even the best intentions. So as you're looking at the plan that you're going to develop and you're suggesting, well, we need to be talking to your physician about this, that, and the other thing before we can do this, that, and the other thing, perhaps you need to just break it down to, I need to talk to your physician. Can I have your permission to do that? Leave it at that and then have that conversation, because everything else is probably just going to end up being too confusing when you're trying to go through the whole list of things that you need to find out. A sponge or a ball can be used to make a handle larger and easier to hold on to. Flossing is easier with fingers outside of the mouth, so using floss aids are usually easier, such as the floss aid you see on the pad there. A bent brush is good for teeth that tip inward. Lower teeth very often tip in towards the tongue, and getting a bent brush that can get back there will provide better access and better ability to see what's going on if you have a mirror and need to bend it extra. And a proxy brush, which is that brush that you see above the dental floss, is used for cleaning in between larger spaces that are present between the teeth. And again, as I mentioned, a manual or an electric brush depends on how well the sensation from that brush is going to be tolerated and how well the operator can move the brush around and get it to where it needs to go. Just because an electric toothbrush is doing the rotating doesn't mean that it's being put into all the places that it needs to reach. So again, recommending these different oral health appliances, you need to make sure that someone is showing proper use and working with the individual who's going to be using it. Is it going to be the patient themselves, or is it going to be a caregiver? Does the caregiver have arthritis, and is the caregiver the one who needs the sponge and the ball in order to help them be able to better help the person they're caring for? So when we're addressing medical complications, this is the crux of what I wanted to get into with today's discussion. Understanding the disease process itself is only part of the overall picture. So providers need to articulate with one another how well controlled a condition is, what are the concerns and the risks for each procedure being performed. So physicians need to be sure that they have a solid understanding from the dentist of what may occur at the visit and what they are asking for in order to provide safe and effective care. For example, we say that we're going to extract a tooth with local anesthesia and epinephrine, and I oftentimes will get, oh no, we don't want any epinephrine. Well, each carpule is 1.7 cc's and the epi is 1 to 200,000, so we're actually talking micrograms over a period of time. So sometimes it's not as frightening as it sounds, and getting that specific information from the oral care provider that you're dealing with is very important. Another thing that we need to be looking at is how long is the procedure going to last. And if we're going to be utilizing any type of physical immobilization, if we are going to, what kind are we going to utilize and for how long? If pharmacologic stabilization or sedation is going to be utilized, is that truly going to be safer for the individual we're working with? Are there aspiration risks? What type of risks do we have if we need to try to rescue this person if the sedation becomes too deep? We've seen individuals whose posturing, their heads are postured downward and they're not able to lift their heads up. And so sometimes providing sedation in those cases is actually more dangerous than utilizing restraints or stabilization devices that may hold the arms down and keep the individual still like a papoose. So we have to, again, make everything based on the individual, based on the needs of the individual, and based on what procedure is being provided. A blanket sedation for every dental visit is not appropriate. There may be visits that are going to be less invasive and require less than visits that are going to be more invasive. So the mouth is finally being put back into the body. I've often said that we should be calling ourselves oralologists, not dentists. And understanding the influence of poor oral health on the overall health and how overall health is reflected in the oral health is the cornerstone to the oral health education. Studies are linking oral conditions to systemic conditions all the time, such as finding oral bacteria in Alzheimer's plaques. Research continues to support the links between oral disease and overall health. Bacteria, viruses, and inflammatory cells in the oral cavity can be spread to all parts of the body, delivered via the bloodstream, the lymph system, saliva, and inhalation. So you cannot hide from what's going on in your mouth. Now, we all know signs of infections as professionals, and yet we very often will tell patients, you know, if you see any signs of infection, give us a call. Well, they may not know what those signs of infection are. We need to assume that they don't know, and we need to be specific in telling them what it is we're looking for, especially if all they've known is infection. They don't necessarily know what normal would look like. They thought it was normal when they brought the person in, not realizing those very red gums and that debris on the teeth that you just removed, and the gums still look red, and you say you cleaned them. Well, they're still red because they haven't healed yet. And making sure that the individual understands there will be a change in that color as things remain healthy is very important to describe. And another thing I'd like to point out here is that a lot of children, when you see the picture I showed earlier with the terrible caries all over, and it looks as though that patient should be in a lot of pain and complaining all the time about their teeth hurting. If that condition is all they've known, for the most part, very often they're not complaining about pain, they're not complaining when they're eating, they're not avoiding eating certain foods because they're so used to that pain. And until you treat the disease, they don't know any better. It's kind of like the person with the deviated septum who doesn't realize they can't breathe normally until they get that deviated septum fixed. Now they take a deep breath in and say, my God, this is so easy. That happened with my daughter when she had her tonsils and adenoids. First thing she said when she woke up was how easy it was to breathe. So that's the kind of thing we need to keep in mind. The parent may say that the child has no complaints, and they may not have any complaints. There was a time when pregnant women did not seek dental care, and some still believe that it is not safe. There are relative contraindications depending on the patient's condition, and therefore consulting with an OBGYN is reasonable. And it's important when you're pregnant patients that you let them know they should be seeing a dentist, and let them know that the first visit should occur when the child has their first tooth or the first year, whichever comes first. Encouraging them to be wiping the mouth out right from the very beginning is extremely important. The reason that we used to only treat during the second trimester was because during the first trimester, most people were having the most morning sickness, and getting in their mouth would often cause them to regurgitate. And during the third trimester, you're just so big you don't want to sit back in the chair, quite honestly. And if you look at the information about the developing teeth, you can see the importance, again, that we put on treating the mother and keeping the mother healthy during her pregnancy, not only for her own health, but also for the health of the child. And we often wonder, well, a lot of women will come and say after their pregnancy they lost teeth because while they were pregnant. And if you look at when the teeth are developing and you consider all the calcium necessary for the baby to be able to form what the baby needs to form. It's probably stealing and leaching from the mother. Can't really measure that, but that's what I've always thought, and that's part of the reason why they have trouble. Plus, they're not feeling well, and they're tired, and they're not taking care of themselves. So as physicians, it's important to make sure that you do have those discussions with your pregnant mothers so that they will be able to be providing good care for their babies and for themselves. So let's talk a little bit about respiratory disorders. Inhalers should be used before oral care at home, and they should always be brought to appointments and kept in the treatment rooms. It's important to share with providers what causes the onset of an attack and the last time they had an attack, how frequently are they, and how frequently they need to use their inhalers. Remind your patients also to check oxygen tank levels for people who carry their own oxygen tanks. And again, here we're talking about the individuals we're caring for and the caregivers. If they have oxygen that they have to carry with them, make sure they're going to have enough oxygen for the appointment and enough oxygen to get back home again. Sometimes if they're left waiting and you're running behind, you may have to have them turn off their oxygen and use the oxygen that you have available in the office in order for them to be able to make sure they'll have enough to get home. Aspiration pneumonia is the #1 reason that individuals with special needs report to the emergency department. It's imperative during treatment that an assistant, nurse, etc. is constantly maintaining a clear airway. You need to let dental providers know if there is a high aspiration risk for an individual, and perhaps consulting with a respiratory therapist regarding pre- and post-appointment care could be suggested. Most oral disease is a germ game. Okay, we have germs that are causing either an affection that is then releasing acids, and the bacteria are releasing acids and destroying the teeth, and then we have bacteria that are destroying the gums and the bone that are holding the teeth in. So if we keep in mind that it's a germ game, then we have to remember that immunosuppressed people are going to have a much higher risk of oral disease. So the healthcare plan may need to include more frequent visits to the dentist in order to keep the overall disease in check. Many concerns will require planning with the primary care provider and being sure that the staff is trained to recognize that there may need to be a plan for these consultations before the first visit to be sure that the information has been shared before the person's first visit. If they may require an antibiotic prophylaxis, if there may be special precautions that need to be taken, those are things that should be shared between the doctor and the patient. By having that conversation will enable providers to perform an adequate examination at the first visit and not waste the person, the staff, or the caregiver's time. Consideration should be given whether we might want prophylactic antibiotics before and after a procedure, or whether or not a regimen of chlorhexidine might be in order to be used before and after a procedure. Some patients can experience severe dry mouth, so be sure to evaluate this and make mouth moisturizing part of their overall care plan. Individuals with PEG tubes also require oral care to remove the biofilm on a regular basis. Many caregivers are not aware of this, and they believe that because the person is tube-fed, there's no reason for them to have to brush the teeth because food is never introduced to the oral cavity. And yes, that does decrease the chances that the sugar will act with the bacteria, but biofilm forms naturally on the teeth, and that plaque will then harden and become calculus, which then can harbor bacteria and cause periodontal disease. So it's important, if you have individuals who have not been PEG tube and then they get a G tube, that you explain to the caregivers that in addition to caring for the G tube, they need to still continue oral care. And if the individual does have xerostomia, even while they're on a G-tube, moisturizing the mouth is important. So putting a saliva substitute on a sponge or something and working around the oral cavity helps to keep the person much more comfortable. A dry mouth is very uncomfortable and not a nice thing to have to live with. Always ask if there are difficulties chewing food or if the diet has been modified due to chewing and or swallowing difficulties. Referral to a speech pathologist may be in order to help with working with swallowing. Again, the xerostomia can also be part of the reason somebody is having problems swallowing, because it's very difficult to get a food bolus down without adequate moisture. So when saliva substitutes are recommended, they should be used before meals or before eating in order to provide that moisture necessary to help get the food down. Perhaps the food doesn't need to be pureed, the mouth just needs to be wetter. People may also be on a thickened liquid regimen, and you have to adjust care accordingly. Most of those supplements, such as Ensure, are high in sugars, and they are thicker in consistency. If the mouth isn't cleaned immediately after, or rinse isn't provided with water to remove it from the mouth, that milky substance will help feed the bacteria that are going to cause an increased caries risk. And if you look at the picture on the far right, I extracted that from a vegetarian. Ha ha. Okay. Failure to thrive, also known as a faltering weight or weight faltering, indicates an insufficient weight gain or inappropriate weight loss. Now, I realize this is a pediatric lecture, but there's been studies to show that in the geriatric population, individuals with oral problems start to show a failure to thrive very quickly when the oral condition starts to go downhill. So when you do see a failure to thrive, one of the first things you might want to evaluate is the quality of the oral care and take a look at the oral cavity. One thing we always want to ask about are changes in weight, whether those changes are intentional or not. If you are noticing a change in weight with your patients, getting in touch with the dentist to find out what information we have from the last time we saw that person may be important. Sometimes we know caregivers forget that the last visit wasn't 6 months ago, it was 3 years ago. Or as I mentioned earlier, when you have so many things to be keeping track of, it's easy to think, oh, they were just at the dentist when they really weren't. Also important to keep in mind with your gastric bypass patients that they have a higher caries risk because they will be eating smaller, more frequent meals. And very often because of that, they're not cleaning their teeth after every little eating session, and that can cause a longer pH drop in the mouth, which then leads to increased caries. This teenager liked to do the do, and as you can see, she done did the do, and the do done did her teeth in. She's now facing a soda pop mouth, as some of us call it, but basically what's happening here is that the soda has a very high acid content or pH that's equal to 2. Then they're drinking this over a long period of time, dropping the overall pH in the mouth for a long period of time. In a non-acidic condition, the bacteria then can also destroy the enamel along with the acid, and then the teeth, of course, are just sort of eaten away. The sooner we get back to the neutral pH, that's when we start seeing the process stopping. So that's why we say it's the length of time that the exposure to the sugars is occurring and not necessarily the amount of the sugar. Know this conversion and become a label reader. Get rid of gummy vitamins and supplements. They sit in the deep grooves of the teeth and they release sugar all day long. Make sure to stress that it's time of exposure to the sugar and the length of the acid attack that is critical. When a baby is fed just before bed, some of the saliva and milk are not going to be swallowed. And if it isn't removed from the mouth with a water chaser or a cloth, it sits in the mouth for hours, and that's where we start seeing that early childhood caries. The most important way to control hypertension and other cardiac conditions is with adequate pain control and reduced anxiety. So plans will need to be modified for the time of day to coincide with regular anxiety medications. The primary care providers should discuss whether or not you can change the dosage schedule to better accommodate anxiety control at the dental office. For example, I've had some individuals who are on medications to help them with sleep and anxiety control in the evening. Is it possible that we could schedule them in the late afternoon, give them that same medication later in the afternoon instead of giving it to them in the evening, and utilize the fact that we already have a medication that we know is safe and effective for that individual to cause some sedation for the dental visit and then just alter the evening dose. So those are conversations that you can be having with the oral care providers and the dentist when you start seeing someone requesting about sedation. Well, if they're already on a lot of sedative medications, maybe we just need to change the timing or the amount of the dosage of the sedative medication to help make their visit more comfortable. Noticing and asking your dental friends or whoever you're talking to, and you need to keep in mind as I'm giving this lecture, I often give it to dentists and medical professionals at the same time. So we want to make sure that we're noticing when there are swelling in the legs, when we recline the chair. We need to be notice when people are winded coming into our office. And it's important to stress taking a blood pressure at the visits in order to establish a trend. What is the baseline for the person when they're just visiting versus their blood pressure when they come in knowing they have a procedure? An oral lichenoid drug eruption is a medication-induced chronic change that occurs inside the mouth, and I have some pictures there. It appears the same as idiopathic lichen planus clinically, and under the microscope, and it will usually resolve when the drug therapy is changed. And again, consulting with the dentist and the dentist consulting with the physician when the condition develops is very important. The lichen planus, you're going to see the white papules, the white lines. You can see the Wickham striae there on the cheek. And it's usually bilateral, and it will clear up when the drugs are removed. If it's erosive, you can start getting a separation of the tissue that can indicate a more serious disease. When we blow air on that gingiva, does it just pull away, kind of like you blow on it and it just kind of pulls away as if you're seeing the top layer just separate like a blister that's coming off. We've also seen an increased risk of stroke in patients with periodontal disease. Again, inflammation is being aggravated by the inflammatory cells associated with the gum disease and the bacteria. So it's imperative that we develop oral care plans that are going to decrease this risk. With neuromuscular disorders, we can write for medically necessary facial massage before appointments and as regular care. Massaging after long appointments while giving post-op instructions is also helpful. Most TMJ, quote-unquote, diagnoses are muscle-related. 90+% are based on muscle spasms of the 5 sets of muscles that work the TMJ. So it's important to have the muscle care looked at and whether or not an individual may require facial massage in order to relieve their symptoms. We can also use stabilizing measures for care, and we can talk about looking at poaching and clearing food and coordination involved for this. Again, this is something that physicians can mention to caregivers. When you have an individual with decreased muscle function, their tongue, their cheeks are not going to clear food from the oral cavity. So it's important that someone can go in there and clean that out after each meal. If you think about how much coordination we use to get food out of our cheeks, someone who can't move their tongue in that fashion is going to have a real problem. With psychological disorders, many times the health history questionnaires don't ask and properly address the various concerns. We need to know whether the patient has any of the, what I like to call the Ds, ADHD, ADD, OCD, ODD, and every one of those can vary, and many people can be very sensitive about putting that into a health history. Very often the medications are going to tell us whether there are psychiatric disorders and whether they're being treated. But as we are discussing with our primary care physicians, we want to make sure that we have a good understanding of what types of things may trigger a behavior and how do they normally control those behaviors in a non-threatening environment such as at home versus being at the medical office or the dental office. People with eating disorders that involve regurgitation, they may have a reverse smile line, or you're going to see a thinning of the lingual surfaces of the teeth from the constant regurgitation and the acid. You want to make sure too that if there are certain changes in personality that occur with a psychiatric disorder, how often do those changes occur and what signs should the provider be looking for? I had an individual with a multiple personality disorder that could change without warning, and one minute I'm talking to an adult, the next minute I'm talking to a child. And knowing that that is a possibility and what might help me recognize that helped me care for her in the sense that I had to be able to switch my behavior techniques and how I was talking to her and the instructions I was giving her for the visit. So you want to talk about that and how you may have to modify the plan and share that information with the behaviorist and the psychologist. Also, individuals with PTSD can have various triggers, including children, and you need to know what those triggers are so that we don't cause any of those triggers during a visit. So sharing that information with the care provider is also important. And issues of informed consent can become a problem when you have an individual with psychiatric concerns giving consent for the patient you're caring for, and whether that person truly is of sound mind to be able to give informed consent for the child that you're caring for. So we need to have that all sorted out ahead of time as well. The R word has gone out. We don't say mental retardation anymore, and we really prefer an intellectual disability or impairment. So if your medical forms that you're sharing or consultation forms still have MR on them, please make that change. And we need to find out too whether or not the impairment is developmental or whether it's trauma-induced, and make sure that we can confirm again who can give consent for care. And each state has their own rules about consent, so knowing who is allowed to give consent is important for each individual. Okay. So even when you're told that somebody cannot understand you, it's important to address them directly. When the person who brings somebody to me stops me from talking to the person directly by saying, oh, well, they can't understand you, or they can't hear you, or they can't answer you, I like to let them know that I treat each person the same way, because talking to someone directly and asking them questions first is a way of developing a rapport between yourself and the patient. And even if they're not able to understand you, or they may not be able to respond, we really don't know how much they truly understand. So by speaking to them and being kind to them, I think everyone can understand nice. And so it's important that we make sure that we treat each person the same way. We talk directly, ask them questions. Then if they can't respond, ask the person who comes with them. So very often there are behavior plans in place, or caregivers will know what causes an emotional outburst. So it's important to consult with people prior to the appointment. You want to be prepared, and the more that you know about the person that you're going to be taking care of, the better you can care for them and the better you can include addressing their needs in the oral care plan. Because if you have time to think about interventions before they arrive, you'll have a more successful visit. So sharing those behavior plans with the dental provider will make each visit more useful. And I already talked about the value of the meet and greet and having them come and just become familiar with the place. Polypharmacy does cause a lot of trouble in the oral condition, and that is mostly seen with the xerostomia. So working towards reducing the medications and adjusting the medications is something that can be shared between providers on a regular basis. As dentists receive their medical histories and they ask for an update on the medications, it means reading the list and confirming the medications and the dosages and when those medications are taken. Again, as these things change, it's important that the dentist and the primary care are talking together so that, again, they can manage the oral care plan according to when those medications are being introduced. These are some conditions that you're going to be seeing. Candidiasis, I'm sure you're all familiar with, or thrush. When this happens with an individual, make sure that they are treating their appliances as well as treating the mouth. You have young teens who may have retainers. If they develop oral candidiasis, you want to make sure that that prosthesis is being cleaned and soaked in the nitro as well, or nystatin, sorry. I have to apologize because my slides going back and forth are not toggling very well. Here's some information for the antifungals. Some pharmacists may question if this is something that's in the dentist's scope of practice, or a primary care may ask. If we are prescribing a fluconazole for a candida infection, then that's, especially if it's secondary to an antibiotic that we have prescribed, it is within our scope to be able to prescribe that diflucan, and it's also within our scope to make sure that we are referring that individual directly to their primary care provider for an evaluation if we're not sure whether that's what the person is describing to us over the phone. So we need to be sure we're talking to one another, and if you have a patient that is known to develop fungal infections after antibiotics, share that with the dentist so that they can let you know, hey, got to put this person on an antibiotic and you may need to address the vaginal infection that's secondary. With some of these mucositis formulations, very often we have to give the compounding information to the pharmacist. So it's very often best to call and ask them if they have a known standard formulation that they're already using, their own magic mouthwash. A lot of pharmacies will have it. Otherwise, some of these ingredients that you see here may not be available. And you can see there a case of the hairy tongue and xerostomia. You can also see a mucositis on the buccal fold in the mouth. And again, those are things that can be caused by polypharmacies. So we want to make sure that we take into account the various side effects, and if we're prescribing a medication that is known to cause xerostomia, do we already have a patient with a high caries risk? And if so, what can we do to perhaps use a different medication or recommend something to help with that caries risk? We talked about xerostomia causing problems with swallowing. We also need to keep in mind that the saliva is what's buffering the acid. So without the saliva, we automatically have an increased caries risk, and we want to be taking care of that. And I'm just going to make a plug for community water fluoridation. If your area isn't fluoridated, get involved with your local dental society. It's very helpful when you are trying to look at the overall health of your population to have this going on. It's helpful for adults and children, especially for children, and it's very important that we know whether or not they're getting adequate fluoride in the water. And become involved in those fights in your community, because when you have medical providers involved along with the dentist, it goes a lot further. We want to be aware, too, that not all of our colleagues are in agreement about what the best intervention is for using fluoride, but fluoride varnish should be utilized every 3 months in individuals with a high caries risk. It's very easy to apply, and if it's not something that you have implemented in your office, it's very easy to do when your children are coming in for their regular visits. It's important that you can add. So then if they're seeing the dentist twice a year and they're seeing you twice a year, they're getting their 4 applications a year to help protect the teeth. Silver diamine fluoride is utilized to help arrest caries. It will turn the caries black over time. So if you do see this in the mouth, do not automatically assume that it is caries. It could be that somebody has applied silver diamine fluoride. We're using a lot of this in children now to help get the caries controlled until they're old enough to come in and be able to be taken care of. Or we're using this on teeth that are going to be exfoliating soon, and we don't want to go through a traumatic procedure in order to care for the caries. It doesn't look good, but it certainly solves the problem. So you may be seeing more of this. Antibiotic prophylaxis regimens, I just wanted to bring to your attention that the American Heart Association has made some changes, and that you should be aware of what the most recent regimens and recommendations are. So I'll go through these rather quickly. And again, joints, the American Association of Orthopedic Surgeons, they've changed their recommendations. And again, that's something to be aware of, and to share your concerns with the dental provider, whether or not you would like to see them covered because of a compounding condition, since now we're basically not covering joints unless there is an extra concern to do so. So to summarize with the interprofessional care, we want to develop a network that we can speak with freely, and among professionals we want to have regular contact with speech pathologists, occupational therapists, behaviorists, pharmacists, social workers, and caseworkers. Having this relationship will make treating individuals with special needs easier. You want to have people that you can call and ask about anything that may come your way. We recommend annual dental visits and evaluations, actually every 6 months, but we want to make it a part of your intake information if you work in a medical office, and vice versa. At the dental office, we want to make sure that our individuals have seen a physician within the last year. And if we work together, we can help keep people healthier in general. We want to remember that the first dental visit should start at the age 1. We want to see healthy teeth from cradle to the grave, or as a friend of mine coined the term, from sperm to worm. Assessment can go both ways. Dentists can detect medical conditions as changes occur in behavior or in the mouth, and care providers should share any changes at each visit with their individual as well. This is an abstract of information for you, and this is the information for contacting me. And at this website, the paoralhealth.org, you will find webinars. There's 5 different webinars available for allied health professionals, and I hope you'll make use of it. And again, I always like to thank the Dental Life Network for the grant that made it possible for us to be able to do those webinars. I'll now take any questions if you have any.
At this time, if you have a question, you can type it in the Q&A box, or you can use #6 on your phones for any questions. Again, that is #6 for your phones, or you can type in the Q&A box for any questions at this time.
Well, thank you everybody for your participation, and if you think of any questions later or you're going through the recording or looking at the slides at a later date, please utilize my email there and send me your questions or give me a call. I'm more than happy to help with whatever I can. You will find some very helpful behavior management webinars available through that paoralhealth.org that will talk about different management techniques you can utilize. They obviously are being utilized within the dental office, but they've also been very helpful in the medical office.
Thank you. This concludes our webinar. We want to thank Dr. Alicia Risner-Bauman for her excellent presentation. Many thanks again to the Pennsylvania Department of Health for the funding that made